And it is my pleasure to introduce today Dwayne Cameron, who's a substance abuse specialist. So just a little bit of his background. Dwayne has over 35 years of experience specializing in the addictions field with a diploma in addictions counseling and a Bachelor of Arts with a major in clinical counseling. He's a certified crisis debriefer, suicide and family intervention specialist, a PART trainer, which stands for Professional Assault Response Training, a motivational interview trainer, and is certified in reality therapy. Dwayne has worked in numerous clinical settings over the years, including intensive residential and family addiction treatment, outpatient, detoxification, corrections, and community development with both youth and adults. He has worked extensively with Indigenous people and was one of the first mental health therapists in 1995 working on reserve with Indigenous communities and Medical Services Branch Canada. Dwayne is a sought-after teacher and workshop presenter. He has taught a variety of audiences from professionals to large youth groups with a sense of humor and a teaching style that brings the information to life in a fun, full impact way. So Dwayne, very thankful for you to join us today and provide your presentation to our group. So I will let you take it away.
Thanks, Jason, and thanks for having me on the webinar today. And one of the things that wasn't in that bio is the fact that I'm now the team lead of concurrent disorders in Saskatoon. So that's a new role that I've stepped into in the last 3 months just to provide the services there. And that's really what I'm going to go over today, is really focusing in on, how do we work with folks who are, what is concurrent disorder in the first place, and how do we work with folks that are struggling with complexity of concurrent disorders. So I'm just going to share my screen and use my PowerPoint to guide me as we go along. There we go. So this was doing this before when I was, hang on a second. For some reason, my PowerPoint was freezing and I had to close it and reopen it. Let's just do that one more time. Of course, it always works good when you're doing the initial trial. There we go. Now you're seeing my whole messy desktop.
No, we see just the slide there.
Oh, you're seeing just the slideshow now? Okay, there you go.
Yeah.
All right. So the concurrent disorder program, really with myself as team lead, and I work with Lisa, who sometimes joins me in these presentations. She's our community mental health nurse that works with us, because we really work as a team here. Is that showing up now? I'm seeing differently than what's actually coming up. What are you seeing right now on the screen? The introduction?
Yeah, it's still on the title slide there.
Heck. There we go. Now it's cooperating. Yep. So in the introduction, really, when we're talking with somebody that has a mental health problem by itself, they usually have a higher risk of substance use. And we're going to talk a little bit about some of the numbers just to give you some framework for that today. But conversely, when somebody has a substance use problem, we're really seeing, and clinically over the years, we've seen a real increase in mental health type symptoms showing up with substance use as well. And so the two are combined. Some of the language we use is concurrent, which is just really means that they have both going on at the same time, both a mental health concern and substances. So another word you'll hear thrown around lots is comorbidity, which really is just the way to describe that concurrent disorder. When the way we look at it from a DSM-5 is they're both primary. In other words, they're both showing up, they're both need to be dealt with at the same time in that person, and you're seeing a variety of hodgepodge of symptoms, really. And so how do you kind of tease that out, and how do you work with that? And I'm going to give you again some highlights on how we work with it here, and what we find is actually changing outcomes in a healthy, positive way with folks. So usually they do occur at the same time, or sometimes what we find is more of the mental health symptoms will kind of rise to the surface, and then they may subside, and then you'll see more of the substance use, or it's really a mishmash, and it's hard to figure out which came first, the chicken or the egg, so to speak. So, and comorbidity also implies that they interact with each other. So one worsens the other. And that's what we mean by the comorbidity language that we throw around. So really, this just gives you a visual. You know, you're not just dealing with a straight mental health or a straight substance use. Concurrent overlaps in the middle with a variety of different substances. So this just gives you a little bit of a, often we talk about in substance use, okay, well, is it biology, genetic, is it environment, is it nature, nurture? All of the above is the correct answer, really, when you look at the research and what's out there. If you look over on the biology side, yeah, your genetics is a factor. Male, female is a factor. One of the things I throw out to people when we're talking about alcohol is alcohol doesn't care whether you're male or female, but if you are female, there's actually an enzyme missing in the liver that helps break down alcohol. So women are, just from a physiological perspective, a little bit more at risk if they abuse alcohol to excess. If there's previous genetic stuff with mental health disorders in your genetics or your family. All right. So we flip back over to the environment side, and a lot of us already know, like if you didn't come from a healthier family environment, if there was abuse, various kinds of dysfunction in the home growing up, even attitudes of significant others in your world can have a factor. It's a significant risk factor for folks. Peer influences we're pretty much aware of. I've gone into lots of different communities over the years, and it's interesting how different communities have different perspectives or attitudes around certain substances and mental health. And that can affect outcomes both positively and negative. And then just poor academic performance and not connected to community, all those kinds of things. So when we talk about the actual drug, though, how they're taking it, what the drug is and its effects, I was thinking about this as we were doing the presentation. In fact, I was doing some training last week, and when I finished my first diploma in specialty in addictions counseling back in 1988, I know that's aging me a little bit, but then we thought the adolescent brain was done developing at 14. That's the best understanding we had of the adolescent human brain at that point. Well, now most of us know that, geez, in fact, I remember reading a book from a great child psychiatrist in the mid-90s and saying, oh my God, we made a mistake. The adolescent, the brain isn't actually finished developing till 18 to 24 in a kind of an age range. And so when folks consume the different drugs or alcohol at an earlier age, that onset is a really critical factor in both mental health and risk for substance abuse. Lots of times we're seeing, it's been coined the crystal meth epidemic in our province, mixed in with the opioids. Really one of the key driver and environmental factor with the crystal meth is it's cheap and it's available. And that's really poured gasoline on the fire in the sense of abuse and the whole realm of different symptoms that come with that. And then that affects the brain, and we see the mental health and the substance use diagnosable disorders coming out. So how common are these concurrent disorders? Well, 50% is what the research shows, that people seeking addiction with a severe substance use disorder, and I'm going to get into that in a second, they're also living with the symptoms of mental illness. So very, very high amount of those folks. And then 30% of the people that are actually seeking help for mental illness are actually living with a diagnosable substance use addiction. And when I say these things, we're using the criteria of the DSM-5. So why do these numbers matter? Well, these stats really reflect both on the severe end of the spectrum. So when we're talking about whether it's mental health illness or substance use, we go from mild, medium to severe. So these stats are really on the severe end of both those conditions on that scale. So that means there's really a lot more people affected than what we're even capturing in some of this data that are impacted, maybe not to the severe end, but are experiencing mild to moderate symptoms of both substance use and mental health. And of course, they often compound each other in the symptoms as they present. So, we're talking about co-occurring disorders. That's what COD stands for, is another term that's throwing. It just means they're both happening at the same time. It really complicates the treatment. And if we don't help people understand and manage those things, both from a multi-team professional approach, it really impacts the recovery. I got a quick story to tell you. Just one of the things we do is we have a psychiatry clinic here that works with mental health and addiction services 1 day a week. We have a psychiatrist runs his clinic out of our office and is not technically a part of our team, but is a part of our team. And it was a little over a month ago. We had a client that myself and Lisa were working with, had been doing okay, but had really experiencing high level of symptoms and relapse. We were only able to engage them through their IM medication with the nurse. That's the only way we could get the person into our offices here, because they were willing to be, compliant with that particular medication. They came in being under one roof. Once we got them in here, I connected with them. We co-worked with them, Lisa and myself. We were able to squeeze them in with a psychiatrist and get a quick assessment on what they needed for adjustment of their medications. And we got the person into some detox and kickstarted back into a safe environment for restarting their recovery. And the reason I'm telling you that story is it's a success story. When we can, figure out ways to collaborate and work together better. I mean, I know it's a bit of a catchphrase, and that always isn't easy. But when we can do that, we can really increase or affect the outcomes with the complexity of issues like that this client was presenting that day. And had just any one of us on our own and all of our good skills and training and everything else, I don't know that we would have got that person along the next level of the continuum of care had we not had the team approach that day. So, but when people are in that, struggling, the mental disorders appear to be on the increase, as are substance use disorders increasing, meaning people with polysubstance use are especially vulnerable. When they start mixing and using a variety of substances, then it really complicates things. When we've got the co-occurring disorders going on, it is often that obstacle to addiction recovery, because there's, it's still, we can't, in my own clinical experience, trying to just manage one and, send them over here to get the other. It can if you're communicating and working together, but we really need that collaborative care when we're dealing with the complexity of untreated mental health and substance use. So, when a person is experiencing mental health disorders, you can see by the list, especially with there's co-occurring substance use, we see higher rates of depression, anxiety, bipolar is a real common one as well, schizophrenia and PTSD. Those are the highly prevalent mental health disorders of symptom packages that we see mixed in with substance use. And those people are obviously much higher risk for suicide as well. The CODs are really associated with the socioeconomic factors. We see that all the time. And we have, working with the other collaborative community teams to work on some of the issues that you see there, like the homelessness and unemployment, and, connecting them with services when they're coming out of the criminal justice system quickly, right? So to create more of that continuum of care. Just to give you a mini snapshot. It's been 6 years since I worked in the men's correctional, 7 years now, actually. And, one whole unit in the men's correctional just here in Saskatoon was all mental health concerns. So people who were incarcerated but had moderate to severe mental health disorders, and they tried to keep them separated from the regular population as a way of safety and protection. And so it just gives you an idea of how it's on the rise and what we're dealing with. So a few models that helps to kind of explain and understand things. It's beyond self-medication. It's really a hypothesis. We don't want to assume that people, just because they're, using substances, they're self-medicating. They could be, and then you really need to unpack what's the reason. What do they see as helpful in a not so helpful way when they're mixing substances and trying to cope with mental health symptoms, right? Here's a little flow chart that shows you, it could be substance use, but it's moving towards mental health. As they use their substances, they start showing more mental health disorders. The reverse can also happen. All right. They have major mental health disorder going on, not using much for substance, but they start using and then they start to develop a substance use disorder. Or the common factor is they're just really all mixed in together and trying to sort out which comes first. We find in the treatment aspect is it can be helpful in the assessment stage perhaps, but really when we're treating and helping people, we work with what presents through the door. We don't, if it's more mental health, we'll focus a little bit on that and medication management and counseling and support services around that. But we also keep an eye on what's going on if we know there's a substance use disorder, because sometimes the next week when they're in, it could flip around and the substance use disorder is more prevalent for what's showing up walking through the office door. Here's what I touched on earlier. Just shows you that, in both when they're diagnosing using the DSM-5, it's both from mild to severe in substance and mental illness. So I like this slide because it just gives you perspective. So, with the general population for anxiety disorders, we're seeing 10 to 25%. By the way, this data is aged. It's higher than that. I don't have the exact because I haven't pulled the exact, but I was reading some stuff recently that says anxiety is even higher than 25% of the general population. But at this time, 24% of those will have a substance use disorder. Same with major depressive. We're seeing 15 to 20% of the general pop, with 27% showing signs of a diagnosable substance use disorder. Bipolar is a big one. So it only affects 1 to 2% of the general population, but 56% of the bipolar folks were also showing a substance use disorder. And that's an interesting one, just from a quick clinical perspective. When folks have come in with that, if they start to get into recovery and, get some medication and get things balanced for the mood swings of the bipolar, they get things sorted out in their substance use area, the symptoms really decrease. The medication works much better, and some are even able to work and reduce medication or less medication. Some need to stay on it, for forever kind of thing. But it's interesting how once they get the substance use dealt with, the mental health symptoms really calm down and are managed quite well. Schizophrenia, 1%, yet 47% are showing up with substance use disorder out of that population. Personality disorders, 6 to 9% of the general pop, 6 to 7.7% in acute psychiatry. So a little different population there with the substance use disorder. And then just in general, 35% of our clients in inpatient psychiatry in Canada have a co-occurrent disorder. I would say, and again, that's 2013 information. I was talking to a psychiatrist inpatient here at Dubai not too long ago, within the last few months, and they figured half of our beds of inpatient right now were drug-induced psychosis. And again, trying to figure out, the whole mental health and the drug-induced psychosis piece is challenging. You'll hear us talk sometimes in the concurrent disorder field of the 4 M's. What is that? Well, masking, because one simple, mental health can mask an alcohol or drug problem, or they can cover or diminish them. They can mimic, one can act like the other. They can trigger symptoms with one or the other and make them worse. And a common one, I watch this in the language, especially around clients, but at staff meetings, we might call it med mucking. But really what it is from a client's perspective, they're trying their best in their own way to work with the symptoms. And they end up taking matter into their own hands without really sometimes working fully or being fully open disclosure with the variety of people on their care team. And so they end up making things worse by mixing the medications or not taking some or those kinds of things. I'll talk to you a little bit about that in another slide here. So, but what happens is clients with concurrent disorders, they generally feel worse when they're coming off a detox. So we're learning that and getting better at that in detox. back in the day, as we say, in the old when I worked in detox, I actually worked in a medical detox in conjunction with a hospital in one of my first jobs. And, some of the physicians were better than others. It's like, oh, it's straight alcohol. We'll give them a little bit of a mild sedative, but, they need to rough it out. Well, now we know that, alcohol withdrawal, you can actually have seizures and they need that, especially if there's a concurrent disorder going. And as they come through the withdrawal from the alcohol, the anxiety really goes through the roof, more than just normal alcohol withdrawal. So we need to medically manage that because, I've had clients in day 2 of detoxing from alcohol and the anxiety's through the roof so bad that they just self-discharge and go get some alcohol in order to try and calm the anxiety. Whereas if we can manage that in a concurrent way with some medications, we increase the opportunity for clients to stick through whatever phase of treatment they're in, especially detox. But depressants like alcohol and benzodiazepines can mask anxiety, panic disorders, and depression as well. And then they start to show up when the person, starts to get some help for their substance use. These symptoms need to be managed, and again, in a care team, better to give the client a better opportunity for recovery. Stimulants will often mask anxiety and mood disorders. Sedatives can mask anxiety, and these are generalities kind of thing. Substance use can also mimic those psychiatric symptoms. One of the big things we're seeing is with the crystal meth. It looks like mood dysregulation, looks like bipolar. But it's normal to have a depressed mood when you're withdrawing from stimulants. Because, I remember having one client that I was working with that's given me permission, of course, without his name or anything, just to share, to help learn from it. This was a 10-year crystal meth user. And he'd been managing and kind of, in and out of job. I mean, managing in a broad sense of the term, but manage. I don't think he'd even had one hospitalization for symptoms around psychiatric symptoms. So managing in the community. Then he got things on track, was in recovery, and he came in for one of his appointments, and he'd had a relapse. And this is his words, quote, he said, "Dwayne, honest, I only had a little point, a couple of hits off of this crystal meth." And he said, "I've been walking for 3 days. I know how to look after myself. I've been hydrating. I've been eating a little bit, even though I don't feel like eating." This wasn't his first time that he had dealt with the manic effects of the crystal meth. But he said to me, he says, "I don't know what they're putting in this crap." I mean, he had a few more expletives to describe it, but he said, "I need extra help. Can you get me into detox today?" So, could you imagine one of us just having one of those school dances back in the 80s where you had a, wake-a-thon and stayed awake for 24 hours. We could do it as a teenager. This guy had been awake for 3 days as a result of the crystal meth, right? So obviously on the other side of that, it's where we need to adjust our treatment, in the sense that people need to sleep more and recover more when they're coming down or coming through the other side of the stimulant, crystal meth. And it has changed. Just clinically and street level, the crystal meth is more powerful. I don't know what all they're putting in it. I'm not a chemist, but I know from clinical feedback from clients, it's stronger and it's cheaper. And of course, when they're going through that, they can be in a high risk for suicide. Just checking on my time here. Okay, we're doing okay. Substances. Here's kind of your main rundown. Alcohol, as we touched on, can make depression worse, anxiety, mood instability. Believe it or not, you can even have hallucinations and paranoia, both mainly in withdrawal from alcohol. Marijuana is the big elephant in the living room these days. I mean, we always saw moderate levels, mild to moderate levels of depression. Lots of us growing up maybe had a friend that decided to try marijuana and got an extreme anxiety attack the first few times they used, so they never used it again. But we're seeing regular users of cannabis that, were using in a regular way, like regular, I'm talking once or twice a week, maybe a little bit more. Then all of a sudden they get some tolerance. They start using a little bit more, a higher THC. And then pretty soon they're using a very high THC level. And we're seeing people show up with anxiety, never had anxiety using marijuana before, high levels of paranoia. I sit on the team with the EPIP, the Early Psychosis Intervention team, And it is surprising the amount of people under 30 years old that are accessing services through that team, and their primary drug of choice is just marijuana. So we're seeing things as the strength increases and the usage increases and those kinds of things that is creating some of those similar mental health kinds of symptoms, right? Cocaine, we don't always think of it that way, but cocaine is a very powerful stimulant as well. Releases a huge surge of dopamine, so we get the depression on the other side. In that, it is a stimulant, so lots of times people are using it, get high states of anxiety. Here's a quick snapshot and just a quick biology 101. Is if you check your resting heart rate right now, most of us are probably, depending on your cardio health, 65, 75 beats per minute. You're sitting there and you take a line of cocaine and your heart rate goes on average to 200 beats per minute. To give you some context, I was working out on the cardio machine in the gym, and it's got all these little warnings in there. If you're 18 years old, do not exceed 180 beats per minute on your heart rate in your work cycle. I'm like, oh, if you take cocaine, even at an 18-year-old, you're above the recommended cardio work rate for your heart, right? So all those pieces it just gives you an idea of how fast the system is revved up. So it's obvious that anxiety and those kinds of things can be part of the package for folks. And withdrawing, we see really that increase and then the drop into the depression side. Hallucinogens, we're seeing a little bit more of this, especially if people are, have read some things online and are using them therapeutically, and they forgot to read the microdosing part. Some of the clients that I was working with, and if one is good, 3 must be great, and so they're really seeing a severity, especially around the schizophrenic type of symptoms in the mental health area. So with the med mucking thing, it's really, they're trying to manage things, but they're not really pulling in the professional and the current research and those kinds of things. And often they're changing their medications, and lots of times it's, if any of you have been around the psychiatry, sometimes they need to be on a medication for a while and really be a self-manager in the sense of not adjusting that, just consistency. One of the things we see in concurrent disorder, when we can get a person, working with a psychiatrist, they're trying a treatment regime of medication, but it's consistent, it's the same time, they're looking after the other risk factors around substance use. But even with substance use, significant substance use, we get that medication piece, that they're taking it consistently and the same and regularly, we can start to see some better symptom management is what we're seeing in concurrent. Now we're going to even see better symptom management if we can deal with the other pieces to the puzzle, like the substance use and all the, the other factors. But really, they're trying to regulate their mood. And, one of the things to talk about clinically all the time, if you take a little bit of marijuana with your medication, it might feel good to help manage the symptoms in the short term, but it's actually adding more fuel to the fire in the sense of the symptom package, usually. So, like I said, in treatment, both are treated as primary, and that's really where it works the best. Clients who get into group therapy, and that doesn't need to be, often in the beginning, they're not ready for deeper psychotherapy, but just psychoeducation, right? And I'm going to go into kind of how we do it here in the next slide or two. But when they're involved with others, they feel less alone. And if it's in that safe environment, they start to learn some things and support one another. Therapy and group therapy environment is helpful in the outcome. And it does require that multidisciplinary team. So you can treat it the 4 main ways. What we find works best is really that collaborative integrated care, and it actually has the best impact on the outcomes going forward. So when we're getting that better care and the better outcomes, what do we see? Well, one of the big things, if you're in the healthcare field, we're trying to reduce some of those high cost admissions, like to hospital, because that's a high cost care, and sometimes that's what's needed. But if we can get ahead of the curve a little bit, then we have lower cost to our systems and less relapses, less of all the multiple effects, increased medication adherence, and those kinds of things. So So, a little overview of the way we work here at the Concurrent Disorder Group. We actually have a full-time addictions counselor / mental health counselor that works right with RUH at the Dubé. And so they will, the staff there on Dubé will maybe make a referral to Concurrent, and then our staff team member can see them while they're there, do a bit of a screening on what they need, and help connect them to the outpatient Concurrent Disorder Group or individual, depending on what they're needing. So what we do is we do a psychoeducational group. It's designed really to, give them information about substance use and mental health and how they interact at the same time. One of the keys is, as probably a lot of you know, there's a lot of stigma. So both with substance use and mental health. I mean, we've gotten better over the years, but it's still out there. And so we go the extra mile to make sure that they are warmly greeted, they feel welcome. There's some coffee and tea around and some, those kinds of things. We encourage them, hey, we encourage their autonomy, trauma informed. Hey, you always have choices. You can come and go. One of our group lines is if you show up to group and you don't feel quite group ready that day, that's okay. You can slip out, and if you can ground yourself and want to come back, great. If you don't feel like you're ready once you got here, that's okay. Check in with one of our staff if you need anything and come back next week. So really open, inviting kind of an environment. We don't need a formal diagnosis for our group. And we find, especially sometimes some of them are struggling and they're not able to get in or to see a psychiatrist, maybe are on a wait list, but they're showing signs and symptoms of mental health illness as well as substance use has been involved, either past or current. That's all we were looking at, that both is showing up in their environment, and then that's the only high level criteria. We do a brief screening for risk of current violence because that's counterintuitive to put them into a group, and so we'll try and connect them with some individual or some other types of services if they're not group appropriate. Some topics we cover, we really spend a lot of time on the overlap and how substance use and mental health multiply each other in the sense of the symptom package and the difficulty in getting into recovery. So again, just helping them in a non-judgmental way understand that, what it means, how to get, how to manage those symptoms. We look at risk factors, and we know that we help them understand that be gentle on yourself, because when you have both co-occurring, relapse is a little bit more common. It can be worked on, it can be identified. You can have, relapse prevention. I call it fireproofing themselves, is one of my coined phrases. So when you have a fire, you know how to get out of the building. When you have relapse symptoms that are familiar to you, you have a game plan on what to do, because under the stress of those things, we don't always think of what they need to do, and especially when they're dealing with concurrent stuff. So we talk about those kinds of things and give them ideas on how to individualize their recovery plan, their safety planning, all those kinds of areas. So we run a 3-month every Friday. So that would be 3 times 4 is 12 different topic sessions over a 3-month period. And they can drop in at any time. If you want to jot that number down, the way to access, the best way is through our centralized intake, the 655-7777 number, because they will do a brief screening and make sure there isn't other services that they need, or they can come through there and come straight to centralized intake over to the Concurrent group. So our groups are done on a Friday, just to give you an idea of the framework. They arrive between 9:30 and 10. We actually do a bit of a pre-screening. It's part of welcoming them, but we're also getting a sense on how well are they doing that day. Are they group appropriate? Because we don't want to pull them out of a group that's already going unless it's, really significant. We want to catch that ahead of time and have an individual chat with them if we think that day that some of their symptoms are presenting and maybe they're not group ready that day. We'll do a little bit of safety plan and work with them. And then we roll our group from 10 to 11 in the education part, just in case you're wondering, because 10 to 12 is a long time for somebody that maybe struggling with some of these kinds of symptoms. 10 to 11 is the actual education part. We take a short break, and then we have what we call a support group afterwards. So the last 45 minutes is, again, voluntary, and it's more where they can share a little bit more from the heart, kind of maybe some of their struggles, successes, maybe how they related to the material that was delivered that day. It's really much more open, and it's facilitated by two of our counselors here. And then we repeat the same topic in the afternoon. So clients have an option of a morning group or an afternoon group, whatever works for them. And it is, like I said, a rolling start date. So they can come in at any time. Not each topic builds on the other. So we have people that have, just come out of Dubai in hospital and joining. We have people, were in active addiction yesterday, and they're recuperating from the impact of the substance use that day. As long as they're functional in group and not disrupting, they're welcome. And then we have, other people that have been successful with some recovery for several years, still dropping in on the concurrent disorder group to freshen their memory around stuff and support others. So that's just our main contact information. If it's an internal referral, then it comes in through the concurrent disorders, kind of our workflow. And we're located down here at Sturdy Stone Center down on 3rd Ave. So I'm just going to run through this. I'm not going to get into depth of it, but this is to give you an idea of some of the relapse prevention and promoting wellness. We really empower clients to become their own expert, help them to learn, grow, by coming to the concurrent disorder group. They learn, but also in other areas. Find ways to manage both problems at the same time. We come from a holistic perspective. So, like my CMH nurse says, pills and skills, right? It's one of her catchphrases, but it's all of those things. It's the skills of eating well, sleeping well, being active and connecting with positive social environments, all that stuff. You can't get rid of stress. Just 2 weeks ago, we did a whole hour just on the differences in managing stress and the stress bucket. We use different ways to try and help them understand that, they're more sensitive to stress being in, possible relapse from mental health and substance use. So as I say with them, your stress management, not doing it so well might be a luxury for the average person. For someone who's struggling with mental health and substance use, it's critical to have some key stress management tools. You don't have the luxury of, putting them on the shelf without having some significant consequences. Support networks, watch for the signs to use, all those kinds of things, asking for help, balanced life. And helping remember them, how and why they need to stay well. Looking back, not to be hard on themselves, but to look forward and really, sometimes when they're struggling with some of their symptoms, it can be hard to remember, you're doing much better than you were previous. And to just put it in perspective sometimes when you're on that journey of recovery and healing. It looks like that's, we got still about 5 minutes or so left for some questions, if anybody has questions. Just trying to find my, sorry, I don't use WebEx very often, so I'm not as.
That's all right. Thank you very much, Dwayne. I think at the top in the screen there should be a stop share if you want.
Oh, there we go.
If you go to the top right in the middle, it might pull down the WebEx. You're right in the middle of your screen there. It should pull down the WebEx.